Good evening, everyone. I'm Jackie Dominguez, National Senior Director of Engagement for the American Liver Foundation, and I'd like to be the first to welcome you to the academic debates presented by Northern California. This educational program is brought to you by the Northern California Planning Committee, Dr. Aparna Goel, Dr. Bilal Hamid, and Dr. Nizar Mukhtar, with influence from the Northern California Medical Advisory Council members. We're excited about our topics, proud of our teams, grateful to our sponsors, and honored to have such an outstanding panel of judges alongside our esteemed moderators. We're grateful that you would take time out of your busy schedule to join us and hope you enjoy the evening. This academic debate is being delivered on the Zoom webinar platform and will be recorded. During the presentations, if you have a question, please hover your mouse over the bottom of your screen and click on Q&A. Then simply type your question into the Q&A box. For all other comments and to cheer on your favorite team, please use the Q&A box as well. Again, please note that this program is being recorded and will be available on ALF's YouTube channel for future viewing. As I mentioned earlier, we are extremely grateful for our sponsors. Our national sponsors are supporting the debates across the nation and include national gold sponsors AbbVie and Eisai, and silver national sponsors Salix. Our national bronze sponsors are Alexion, Mallinckrodt, and Pfizer, and our expo sponsor is Exact Sciences. Let's hear what our national gold and silver sponsors have to say. We are so appreciative of our sponsors' support. We encourage you to thank them when you visit with them. Without their support, we would not be able to continue to fulfill our mission. I wanted to give a shout out to those who tirelessly dedicate themselves to the liver patients and caregivers, the Northern California Medical Advisory Council. They meet quarterly to work with the ALF to provide education for healthcare providers and patients, addressing the unique needs of those in Northern California. Look at this. You just saw an impressive list of liver experts. We're so honored to have them guide us as we fulfill our mission. A special thank you to our Northern California co-chairs, Dr. Jennifer Guy and Dr. Courtney Sherman. Before I introduce our moderators, I wanted to acknowledge our technology team, Barb Potter and Karen Irwin, and the newest member of ALF's engagement team, Nancy Clemens. We couldn't do this without their expertise. And now it's time to turn the program over to two people who really don't need an introduction. They are very well-respected members of the Northern California medical community and beyond. Please join me in welcoming our moderators for tonight, Dr. Aparna Goel, who will be saying a few words about the history and format of tonight's debates, including our interactive audience poll, followed by Dr. Nizar Mukhtar, who will explain how you can help support the mission of the American Liver Foundation, promote the debates through our social media, and introduce our esteemed panel of judges for tonight's debates.
Thank you, Jackie, for the introduction. I'd like to welcome everyone today evening for our academic debates. It's my pleasure to be moderating this with my dear friend and co-moderator, Dr. Nizar Mukhtar. The academic debates have been hosted by the Northern California Medical Advisory Council for several years now, and we've been honored that the academic debates have been recognized for its excellence and have become a signature program of the American Liver Foundation and of the ASLD. The topics and the teams tonight were selected by the members of the ALF's Medical Advisory Council, that impressive list that you saw. Tonight, it's our pleasure to present 4 debate teams of 2 young investigators each who have been mentored by senior investigators. Each team will debate opposing sides of their assigned topic. It's worth noting that the topics and the positions were assigned randomly. The presenters will be sharing a PowerPoint presentation and will have 8 minutes to initially present. The team members will then follow with a rebuttal and will not be using a PowerPoint presentation for their rebuttals, and will have 5 minutes to argue their support of their case. Each speaker is closely timed. If at any time a presenter or rebutter exceeds their time limit, their microphone will be muted by our timekeeper. We really do not like doing this, so we'll hopefully not need to do this tonight. The question and answer for each topic will occur at the conclusion of the presentations and the rebuttals. Each judging panel consists of 3 liver experts, and the Q&A will last about 5 minutes. We encourage all audience members to participate in the Q&A, and you can do so, as Jackie mentioned, through the chat feature in Zoom in the webinar. Remember, there's no right or wrong answers to these topics. However, there may be very strong opinions for one side or the other, which can often lead to a very lively debate. Remember as well, judges and audience members, that you may have very strong opinions, but we encourage you to keep your opinions to the side and to purely judge the debate based on the quality of the presentation. We provided the criteria to the team members to focus on creating professional and well-researched PowerPoint presentations, and to ensure their rebuttal skills are thoroughly researched and make sure that they're prepared to think quickly on their feet during the Q&A. Additionally, to include an interactive component for our audience, I want to mention that there will be audience polling throughout the evening. Questions will be posted periodically, and we hope you take a moment to respond. This really does allow for a more lively discussion during our Q&A session. Of course, please feel free to also cheer for your favorite team by posting a message in the Q&A. The chat function will not be available. My apologies, so I correct that. The chat function is not available, but the Q&A can be used for questions and to cheer on your teams. We would like to acknowledge the hard work of our teams and express our gratitude and appreciation to our sponsors, our judges, our timekeepers, the technology team, and all of our volunteers. Just as importantly, we thank you for joining us this evening. At the conclusion of the evening, all team members will be recognized for their outstanding work, their presentations, and most importantly, their dedication to the liver community. It's my pleasure now to hand the program over to my co-moderator for the evening, Dr. Nizar Mukhtar.
Hey. Good evening, everyone. Welcome. It's indeed my honor to co-host this with my great friend and esteemed colleague, Dr. Aparna Goel. So thank you for joining us. As many of you know, the American Liver Foundation is celebrating its 45th year. Bravo. Despite the pandemic and due to the resilience of the American Liver Foundation staff, our stakeholders, local leadership, and our partners, we stand strong in our commitment to provide resources to the liver community, and the available resources far exceed the excellent literature and information on the website. Virtually, the American Liver Foundation continues to provide opportunities to unite the liver community through events such as the walks, marathons, Cuisine for a Cause, and patient and healthcare professional education programs. There has been a significant increase in callers to the American Liver Foundation helpline and visits to the website, proving the relevancy of our information and services. We take a leadership role in advocating on behalf of the millions of Americans living with liver disease and maintain a reputation for serving as the patient voice. The American Liver Foundation is a not-for-profit organization and as such relies on donations to carry out its mission, and I encourage you all to, no matter how small, make an effort to make a small donation. Please save the date for the American Liver Foundation's 45th anniversary Legacy Gala. It's on October 21st, and I think that our team will be sharing more details about that soon. I encourage you all to use social media throughout the evening and to follow the debate's Twitter feed throughout the program at the @ALF Debates handle. Before I introduce our first topic and team members, it's my privilege to introduce our outstanding panel of judges. These judges will join us at the conclusion of each debate to ask thought-provoking questions of our debate teams, which will no doubt inform the winner of each debate. So this outstanding panel of judges will be deliberating both debates. We have joining us Dr. Marina Reutemann from University of California, San Francisco Medical Center. She's a professor of clinical medicine and the UCSF Fresno Liver Program Director. We have Dr. Vinay Sundaram joining us from Cedars-Sinai Medical Center, where he's the Director of Hepatology Outcomes Research and Assistant Medical Director of the Liver Transplant Program. And lastly, we have, but not least, Dr. Robert Wong from Stanford University, Clinical Associate Professor and a powerhouse researcher and leader in the field of hepatology. So I'd like to introduce our first debate, which is entitled, the debate topic is entitled, Biopsy Should Be the Standard of Care to Assess Non-Alcoholic Steatohepatitis, or NASH. And we'll be going through the pro, con, and rebuttals as shown on this slide. So before we start the debate, and I should say that the pro team will be presented by California Pacific Medical Center, and the con team will be UC Davis Medical Center. But before I introduce our first speakers, I'd like to ask the audience to participate in a quick poll. And you'll see something pop up. And the question is, do you feel biopsy is the standard of care for assessing NASH? Yes or no? And I'm going to give you about 20 to 30 seconds to respond. Okay, great. So we can see here, we're quite split, 56% saying yes and 44% saying no. And so we'll come back to this at the conclusion of the debate. So now I'll introduce the debate teams. And so presenting the position that biopsy should be the standard of care to assess NASH is the California Pacific Medical Center. Their mentor is Dr. William Holt, and the fellows that I'll be presenting are Dr. Andy Liu and Dr. Ann Robinson. UC Davis will be arguing the con that biopsy should not be the standard of care to assess NASH. Their mentor is Dr. Christopher Bowlus, and the fellows representing the UC Davis team are Dr. Zheng-Hsien Ko and Dr. Shivani Shah. So without further ado, I think Dr. Ann Robinson will be starting us off from CPMC with their pro argument, and she'll now present their position. Give her some time to get the presentation up. Great. And timekeeper, are you ready? You may begin.
Okay. Good evening. My name is Ann Robinson. Together with Dr. Andy Liu, we will be presenting the pro argument for biopsy should be the standard of care to assess non-alcoholic steatohepatitis. Without a biopsy, you can only suggest non-alcoholic steatohepatitis, but you cannot diagnose it, as NASH is a histologic diagnosis. When studies discuss what the performance of any non-invasive test is for evaluating NASH, this is always in comparison to the liver biopsy, as it is the gold standard for this disease. NASH is defined as the presence of hepatic steatosis with or without fibrosis, and most importantly, the inflammation with hepatocyte injury or ballooning, where hepatocytes undergo a form of apoptosis. Despite NAFL and NASH often being used interchangeably, the natural history of NAFLD is fairly dichotomous. The pathway that NAFL progresses to fibrosis and other serious disease is via NASH. Images A and B correspond to the steatosis seen in NAFL, and it is through image C, or NASH, that we progress to more severe disease, such as fibrosis, cirrhosis, or hepatocellular carcinoma. Liver biopsy is currently the most reliable approach for identifying the presence of steatohepatitis and fibrosis in patients with NAFLD. If we can identify and aggressively treat our NASH patients, we can prevent progression to end-stage complications associated with chronic liver disease. So why is it important to know which patients specifically have NASH? This is for disease prognosis. Patients with histologic NASH have an increased liver-related mortality rate. In a meta-analysis by UNOSI on the epidemiology of NAFLD and NASH, they found that liver-specific mortality rates among NAFLD were determined to be 0.7 per 1,000 person years. Comparing that to those with NASH, whose liver-specific mortality rates were over 11 per 1,000 person years. When looking at overall mortality rates, NAFLD leads to 15 per 1,000 person years in comparison to NASH, which is over 25 per 1,000 person years for overall all-cause mortality. Why is liver biopsy the gold standard for diagnosing NASH, and why does it remain the gold standard? This is because there are no accurate non-invasive tests for steatohepatitis. Non-invasive tests such as FibroScan and MR elastography can provide some helpful information on the assessment of liver fibrosis. However, they do not reliably reflect the spectrum of liver histology in patients with NASH versus NAFL. We need to remember that ballooning is what delineates NASH from its less aggressive counterpart. Of the clinical and laboratory parameters used for NASH specifically, the best studied is cytokeratin 18. And remember, this is looking at steatohepatitis. Cytokeratin 18 is a breakdown product resulting from caspase-3 mediated apoptosis of hepatocytes. In a multi-ethnic cohort study, the sensitivity and specificity of cytokeratin 18 to detect non-alcoholic steatohepatitis was only 58 and 68% respectively, making this test overall inaccurate for the diagnosis of NASH. Other additional information which can be gathered by liver biopsy is that we can diagnose NASH at an earlier stage before the fibrosis develops. We may also obtain specific and precise information on the staging of fibrosis. This is important as it predicts mortality in these patients. You may say to yourself that if fibrosis is really what predicts mortality, then why would we need a test further than FibroScan or MRE? This is because with biopsy, we can identify patients earlier in their disease before they progress to fibrosis. We can also obtain more precise information on liver staging, differentiating from F1 to F2 to F3 and so forth. In a study by Dulai, we can see that both liver-related mortality in the top chart and all-cause mortality in the bottom chart rise dramatically with each individual stage of fibrosis. Additionally, there are pitfalls in non-invasive testing, and one is that stiffness is not the same thing as fibrosis. Several factors may cause an elevated liver stiffness, including acute inflammation, very commonly seen in NASH, as well as passive hepatic congestion. Other factors include operator variables, patient factors, which include obesity and potentially eating prior to the test being performed. It is also important to note the testing characteristics of MRE and that the negative predictive value for F1 is 73%, meaning that we are missing 1 out of every 4 patients with fibrosis. The future of NASH is dependent upon the information we obtain from a liver biopsy. This is clear in that the inclusion criteria for NASH clinical trials all require a liver biopsy. This is required for both the diagnosis as well as the histologic assessment of treatment endpoints in phase 2 and 3 clinical trials. This is because it is the changes in histology, not just fibrosis, that are associated with endpoints and outcomes in this disease. And this is why biopsy will continue to be the standard of care until we develop something that can non-invasively relay this prognostic information. Given that NAFLD without steatohepatitis or fibrosis is a much better prognosis, at present, pharmacological treatment should be limited to biopsy-proven NASH as per current AASLD guidance statements. In summary, biopsy should be the standard of care to establish non-alcoholic steatohepatitis or NASH. This is because, in its definition, NASH is a histologic diagnosis. There is no test that can assess for hepatocyte ballooning or provide precise data on fibrosis, more specifically F1, F2, F3, and the very specific differences between those stages, which impact mortality. Importantly, NASH also gives us, the biopsy gives us information on prognosis in the disease, whether a patient will continue to have bland steatosis versus if they have NASH, which will progress to decompensated cirrhosis, HCC, and other complications. Lastly, it is essential for future research and advancement of this disease that affects a significant portion of the global population. Thank you.
Okay, excellent. Thank you so much, Dr. Robinson. And so now we have from UC Davis, Dr. Jeffrey Ko, who will argue that biopsy should not be the standard of care for assessment of NASH.
Good evening, everyone. As stated earlier, UC Davis will be arguing the position that biopsy should not be the standard of care to assess non-alcoholic steatohepatitis or NASH. As we all know, NASH is a histologic diagnosis characterized by hepatocyte ballooning, lobular inflammation, and fibrosis. Thus, liver biopsy is frequently performed for the diagnosis of NASH. This is reflected in our AASLD 2018 guidelines for non-alcoholic fatty liver disease, where they state that liver biopsy is currently the most reliable approach for identifying the presence of steatohepatitis and fibrosis in patients with NAFLD. However, the guidelines do also mention some of the limitations of biopsy, saying that biopsy is limited by cost, sampling error, and procedure-related morbidity and mortality. Thus, there is significant interest in developing clinical prediction rules and non-invasive biomarkers. With the market progress that has taken place over the past few years in the field of non-invasive testing for NAFLD, we really should be asking ourselves at this point in time, should liver biopsy remain standard of care for NASH? Again, we are arguing the position that biopsy should not be the standard of care to assess NASH, with our key points being that the diagnosis of NASH does not currently affect the management of NAFLD. The diagnosis of advanced fibrosis and cirrhosis in NAFLD is more clinically important and can be assessed non-invasively. And liver biopsy has some major flaws. It is subject to sampling error and inter-observer variability. It is not cost-effective, and it carries risk of morbidity and mortality for our patients. To our first point, the diagnosis of NASH does not affect the management of our NAFLD patients in our clinic. As we all know, there are no FDA-approved treatments specifically for NASH, and as per our 2018 AASLD guidelines, this applies to metformin, GLP-1 agonists, vitamin E, and bariatric surgery. Pioglitazone does deserve special mention in that it has been demonstrated to improve liver histology in NASH, but not clinical outcomes. However, its use in NAFLD and NASH is currently off-label. We also must consider the risks of pioglitazone, which include weight gain, heart failure, and bone loss, all of which could be counterproductive for our typical NAFLD patients. In terms of lifestyle modifications, they essentially remain the same between NAFLD and NASH. Weight loss through diet and exercise, avoidance of heavy alcohol use, management of cardiovascular risk factors. Thus, labeling a patient with NASH doesn't really affect the way we treat them in clinic. What does matter, however, is how much fibrosis that they have. And as we all know, fibrosis stage is correlated with both all-cause mortality and in an exponential fashion, liver-related mortality. Thus, when considering our NAFLD paradigm, we should really be focusing away from NASH and towards the diagnosis of fibrosis and cirrhosis for a patient. Thankfully, advanced fibrosis and cirrhosis and NASH can be assessed non-invasively. As we all know, there are already available, commercially available non-invasive tests supported by the AASLD 2018 guidelines for the diagnosis of advanced fibrosis in NAFLD. And in an excellent paper by Villar Gomez et al., where they utilized a two-step non-invasive strategy, starting with the FIB4 index and proceeding either to vibration-controlled transient elastography and magnetic resonance elastography, comparing this to liver biopsy in a hypothetical cohort of 100,000 patients with a 2% prevalence of NASH cirrhosis. They found that the two-step non-invasive strategy has comparable accuracy to any modality using liver biopsy and is significantly more cost-effective than liver biopsy. Again, to reiterate, we already have commercially available non-invasive tests that are supported by our guidelines for the diagnosis of advanced fibrosis and NAFLD. And if these tests are utilized correctly, they are as accurate and more cost-effective than liver biopsy. Finally, we must talk about some of the major flaws of liver biopsy. The first of which is that it is subject to sampling error in NAFLD and NASH. A sentinel paper that came out in 2005 from Ratsu et al., where 51 NAFLD patients underwent 2 liver biopsies, it was shown that the agreement between the 2 liver biopsies for most of the features of NAFLD was moderate at best and poor for many features. This is especially the case for the features of NASH, where for hepatocyte ballooning and perisinusoidal fibrosis, agreement between the 2 biopsies was moderate at best with a kappa value of 0.4, whereas the agreement for lobular inflammation between the 2 biopsies was poor with a kappa value of 0.13. This demonstrates the fact that the features of NAFLD and NASH are distributed unevenly throughout the liver, and thus single liver biopsy is significantly subject to sampling error. Next, liver biopsy is also subject to inter-observer variability in NAFLD and NASH. In 2 papers that were published roughly 10 years apart, where a number of pathologists evaluated a number of NASH and NAFLD liver biopsies, it was shown that agreement between the pathologists for the key histologic features of NASH, which are hepatocyte ballooning and lobular inflammation, was quite poor overall compared to the other features of NAFLD, thus demonstrating another flaw of liver biopsy in that it is subject to inter-observer variability. Liver biopsy is also expensive. It's estimated that liver biopsy costs between $2,000 and $7,000 depending on insurance status, and there's a lot that goes into the cost of liver biopsy, paying the physicians, the nursing staff, facility fees. Transjugular biopsy is more expensive. There are also significant unmeasured indirect costs. For example, the lost work for patients and caregivers when they have to take a day off to get a liver biopsy. And finally, if the patient ends up developing a complication or gets admitted, that adds even more cost. In a paper by Allen et al., where they assessed total healthcare cost and resource utilization in over 100,000 new NAFLD patients with commercial insurance matched to non-NAFLD controls, what they found was that in the first year of diagnosis of NAFLD, the healthcare expenditures were about $7,800, and in subsequent years, about $3,800, whereas in non-NAFLD patients, the annual cost was about $2,300 per year. Interestingly, what they found was that the largest increase in NAFLD healthcare utilization was liver biopsy, going from a rate of 0.8 per thousand to 44 per thousand. And that's a rate ratio increase of 55, which was much more than rate ratio increases for imaging and hospitalization. And this demonstrates the fact that if there was any area of healthcare utilization in NAFLD that should be curtailed, it should be unnecessary liver biopsy. Finally, we have to talk about the risks of liver biopsy to our patients. Up to 84% of patients can experience pain, whether it's mild requiring no intervention or severe requiring hospitalization. The admission rate is estimated to be about 3%. And in a paper that came out of Mayo Clinic in 2016, the major adverse event rate was estimated to be about 0.7% in over 6,600 liver biopsies. The rate of hematoma requiring transfusion or intervention was about 0.5%. The rate of infection was about 0.1%. The rate of death was about 0.05%. And while we concede that the major adverse event rate might seem low, the absolute number of admissions and complications will rise if liver biopsy becomes standard of care for NASH. And this is where we have to account for the epidemiology of NAFLD and NASH in the United States and the millions of people that are affected by these conditions. We have to ask ourselves, how many more people will be hurt unnecessarily if liver biopsy becomes standard of care for NASH? Thus, we return to our original question: should liver biopsy be standard of care to assess NASH? Again, diagnosis of NASH does not currently affect management of NAFLD, as there are no FDA-approved treatments specifically for NASH. Diagnosis of advanced fibrosis and cirrhosis in NAFLD is more clinically important and can be assessed non-invasively. Again, there are already commercially available non-invasive tests that, if used correctly, are as accurate and more cost-effective than liver biopsy. And finally, liver biopsy has some major flaws. It's subject to sampling error and inter-observer variability. It is not cost-effective, and it carries risk of morbidity and mortality for our patients. Thus, we conclude that liver biopsy should not be the standard of care to assess NASH. Thank you for your time.
Great, thank you, Dr. Ko, that was great. And so now Dr. Andy Liu from CPMC will be given 5 minutes to rebut the UC Davis position and provide any additional arguments for why biopsy should indeed be the standard of care in our assessment of NASH patients.
Yeah, my name is Andy. I'm one of the transplant liver and gastroenterology fellows here at CPMC. Thank you for this opportunity. I wanted to address some of the points that Dr. Ko mentioned. He had said diagnosis of NASH does not affect management, which I disagree with, and I will go into why. And he also says that, I agree that biopsy is not standard of care for fibrosis. There are non-invasive measures for that. But the topic for this debate is specifically, is biopsy the standard of care for the diagnosis of non-alcoholic steatohepatitis? And absolutely it is. The liver biopsy is the only reliable approach for the presence of steatohepatitis. The non-invasive tests, MRE, the ones that are mentioned, even cytokeratin 18, simply the sensitivity and specificity is not sufficient to diagnose NASH. And this is critical because of the prognostic value of NASH. If you cannot accurately identify NASH patients, you would identify patients that are higher risk for progression of fibrosis, and independently patients that are at risk for cardiovascular disease. So all of these non-invasive measures cannot assess for ballooning. So as early as 1999, Mattioni, they demonstrated this. Patients with ballooning have worse outcomes in cirrhosis and mortality. Even a follow-up study, this is Kaisaka in 2018, they demonstrate that ballooning predicts progression to fibrosis. So, these non-invasive measures to assess for fibrosis, you're missing the whole chunk of patients that have steatohepatitis but don't yet have fibrosis, and this is an opportunity. So, I'll take a moment to address, the cost, the morbidity and mortality. So, there have been significant improvements in the safety of liver biopsy. The admission rate that you mentioned, that's 3% from 1993. A more recent study, this is a retrospective study just published in June 2021, Timades, they found that hospitalization was 0.65%. So initially, biopsy mortality reported in 1999 was 1.6%. That's improved to 0.2% when studied in 2010. And then when looking at all the data more recently, the last decade, mortality is now down to 0.01%. And so in terms of the diagnosis for NASH with liver biopsy being gold standard, this is supported by the FDA and clinical trials by upholding the standard that they require the NAFLD activity score because there is nothing better than biopsy when you're defining disease severity, prognosis, and response to treatment. So in terms of our practice as academic hepatologists, we should also strive for this level of evidence-based practice. And so addressing one more point, I agree, detection of fibrosis as a surrogate for poor outcomes is helpful. But this does leave out the significant patients that have NASH. And so, using fibrosis as a surrogate for NASH is simply not accurate and incorrect. So I agree that the ideal is we have a non-invasive test. I 100% agree that's what we should strive for. But as it stands now in 2021, the question being asked, should biopsy be standard of care for NASH? There's no question that this is the standard of care. Even if I use the highest rates for sensitivity and specificity for non-invasive markers, using either cytokeratin or MRE, the best sensitivity I can find is 80%. And so what that leaves us is with a false negative rate of 20%. And as you mentioned before with the statistics, there's about 330 million Americans. And on the low estimate, conservative estimate, approximately 82 million people have NAFLD on the spectrum. At least on the low estimate, at least 5 million patients will have NASH. So if your sensitivity is only 80% and leaving you with a false negative rate of 20%, you have at least 1 million patients that are left with untreated NASH. And as new developments, new medications come through the pipeline, you're missing a large proportion of patients that would be eligible for treatment. And the flip side is the same for specificity. At the best, your specificity is 87%, and then you have 13% of patients with false negative, and these patients would be subject to future NASH treatments unnecessarily. So in conclusion, non-invasive testing is not ready to replace liver biopsy as the standard of care for NASH.
Thank you for your compelling arguments. And so lastly, we'll turn it over to Dr. Shivani Shah from UC Davis, who also has 5 minutes to rebut the CPMC position and provide us with any final thoughts on why liver biopsy should not be the standard of care.
Hi, everyone, and thank you for your time. It's wonderful to meet all of you virtually. Our stance, again, is that liver biopsy should not be standard of care, and I'd like to start our discussion with some numbers. As mentioned by my colleague, Dr. Ko, the rate of adverse events in liver biopsy by studies is about 0.7%. If the estimated 16.6 million patients with NASH in the United States underwent biopsy, there's a projected 830,000 patients that may suffer from an adverse event from liver biopsy. I'd also like to draw an analogy. We have a diagnosis in hepatocellular carcinoma. We all know that the LIRAD system is far from perfect, and there's a lot of variability between radiologists in terms of diagnosis. However, we are able to definitively diagnose HCC and give chemotherapy based on imaging alone, so much so that our AASLD guidelines actually do not recommend biopsy for routine lesions above 1 centimeter. And therefore, part of the question is if we're able to make these strides in technology to diagnose a cancer and give chemotherapy recommendations, why can't we do the same for fibrosis? As kind of discussed by my colleague, Dr. Ko, the outcomes and studies all in NAFLD in terms of NASH have shown that fibrosis staging is what's associated with worse outcomes. And there's a couple studies that Dr. Hagstrom and Angulo actually recently in 2015, 2017, large scale studies that actually show presence of steatohepatitis actually is not associated with shorter survival times in patients without fibrosis. Therefore, the question we really should be answering ourselves is, does the biopsy change management and identification of fibrosis? Another point I'd like to bring up is that we currently still do not have any effective therapies for NASH. Many patients with NASH, the leading cause of death is actually cardiovascular disease. And so the treatment should really be focused on treating the underlying risk factors. There recently was a study, the STELLAR trial studies, as of in 2020 with the selonsertib trial for patients with bridging fibrosis or compensated cirrhosis due to NASH, which actually had to end early due to the fact that this medication was proven to be non-efficacious. based on that study, actually, there was actually a subgroup analysis, which by Anstey et al., which actually showed that they were able to show non-invasive testing. They were able to show differentiation between fibrosis, which again, based on multiple recent studies, is actually what's more associated with outcomes in fatty liver disease rather than the presence of ballooning or not. And the other part to this too is in terms of limitations of the liver biopsy. We agree that our methods currently may not differentiate finite between F1, F2, F3, F4 fibrosis. However, the same can be said about liver biopsy. A paper by Ratziu et al. Actually showed that there is in patients that receive 2 separate biopsies, show that there's actually a difference in fibrosis stage in 41% of patients. It's not an insignificant amount. And so, again, another reason against the liver biopsies. One other point I'd like to bring out is that there are new data coming out that actually shows that we can use liver stiffness measurements in MRE to actually make a trend. And one paper by Ajmera et al. Actually showed a 15% increase in liver stiffness measurement, maybe associated with histologic fibrosis progression. Therefore, we're coming out with more and more studies in recent times actually to support this, that we are able to non-invasively assess fibrosis, which we believe is the crux of identification of NASH. One other point I'd like to make is that if we were looking for steatosis in particular, we do have some new radiologic imaging that's on the horizon, the MRI proton density fat fraction, the MR-PDFF, PET scans. Again, multiple different things that we could do to spare these patients unnecessary liver biopsies. Now, with respect to serologic testing in liver biopsy, the NAFLD fibrosis score has actually been shown to have a high accuracy, a positive predictive value of 90% and 82% in estimation and validation groups. So it is a possibility, and also combining some of these fibrosis scores with imaging studies may also be of clinical benefit too. So in closing, our stance is that liver biopsy for assessment of non-alcoholic steatohepatitis should not be the standard of care. We have many novel, non-invasive ways of assessing fibrosis as well as steatohepatitis. Biopsies are time and resource intensive, costly, and are associated with a non-negligible risk to our patients. Biopsies also currently do not change any management at all with respect to NASH. Thank you so much for your time this evening.
And so we will now be transitioning into our Q&A session. I'd like to welcome our judges, Dr. Marina Reutemann, Dr. Vinay Sundaram, and Dr. Robert Wong, and both of our teams. And we'll be opening the floor up for questions. And, just to recap the very strong arguments posed from both teams, we have the pro team from CPMC arguing that NASH is a histologic diagnosis, and biopsy can actually help us identify earlier stages of fibrosis, that FibroScan has a suboptimal negative predictive value that can make us miss 1 in 4 patients with NASH, and so this can translate to up to 1 million patients being missed the diagnosis of NASH, and that using fibrosis as a surrogate for NASH is not adequate. And that we're not ready to have non-invasive tests take center stage in diagnosing or assessing NASH. On the con side, we have UC Davis provided very compelling arguments as well. They say biopsy is limited by cost, sampling error, and morbidity and mortality. And similarly, if we start to invoke biopsy for larger numbers of the population, we can see that morbidity and mortality reach up to 1 million cases or close to that. The diagnosis of NASH, they feel like, is actually not a just histologic diagnosis, but is a clinical diagnosis, and that right now, at least, biopsy doesn't really change the management in a substantial way, and that fibrosis stage is more important. Fibrosis stage can actually is more important and can be assessed with a combination of non-invasive markers like FIB4 and elastography. And that this is just as effective as assessing fibrosis via biopsy, and that there are other non-invasive scores like the NAFLD fibrosis score that can be utilized. And so, very compelling arguments from both teams, and I'm sure I left out some important things, but this will be helpful to have the Q&A session, and so I'd like to open it up to our judges. Who would like to start us off? Feel free to just unmute.
Go ahead, Marina.
I have a question to the CPMC team. The COVID-19 pandemic had certainly showed us the limitations and the fragility of our medical care system. Can you comment on the feasibility and practicality and potential limitations of making a liver biopsy a standard of care, not only in academic institutions, but in the community as well?
Dr. Roman, no, I certainly, that's a good point that, when we have to choose between a resource allocation, the burden of liver biopsy would be difficult. But I think in terms of establishing guidelines on what the standard of care should be, I would still stand by that this biopsy should be standard of care for NASH, and then leave it to the clinicians and within their practice environment to make that clinical judgment. And we oftentimes do this where we make the best inference and then we move on to management from that. But I think it would, I still stand firmly that we should not move to non-invasive testing or using other circuits, because that doesn't achieve the correct diagnosis in many times.
I want to follow that, if I can, with a similar question, and this is for, I guess, both the CPMC and UC Davis team. So you guys mentioned that estimates in the US, at least 80 to almost 100 million patients with NAFLD, and a subset of those have NASH. I'm curious, first for the CPMC team, are you advocating for biopsying all 100 million patients, or what subset of those patients, and how would you identify which patients to biopsy to best allocate resources, et cetera? And on the flip side, for the UC Davis team, definitely understand your stance and position on not supporting biopsy as standard of care, but are there a subset of patients that you would advocate for liver biopsy for NASH diagnosis or staging? Thank you.
Perhaps CPMC, I don't know, Andy, if you're, Dr. Liu, if you're responding, but you're on mute.
Okay, we were just coordinating who was gonna respond.
Oh, okay, sorry.
Yeah. We're happy to go ahead first. Actually, could I get? I'm just.
I think Dr. Wang was asking if you're advocating for biopsies to be the standard of care, how are you going to make that happen for 100 million patients? And if you're not going to offer it to all 100 million patients, how are you stratifying or risk stratifying and allocating liver biopsy to specific patients?
No, okay. Thank you, Dr. Mukhtar. No, Dr. Wang, I'm definitely in agreement. It wouldn't be practical, and I don't think I'm advocating for biopsy of everyone with NAFLD to distinguish between bland steatosis and NASH. I think we would use the same risk factors, clinical judgment, risk factors from metabolic syndrome, diabetes, hypertension, obesity, findings on ultrasound, increased echogenicity or heterogeneous echotexture to point us in the direction. And then within that subset, we can also use the scores to help us. When I'm concerned that someone has NASH, I do want to identify these patients that are at risk for progression of fibrosis before they progress to fibrosis, or if there's any question between someone with bland steatosis and I can see in clinic once and then recommend the same dietary modifications versus someone that I think is high risk, requires the biopsy, and I do think that does change management when when a cardiologist or anyone else or primary care physician is telling their patient you need to lose weight, exercise. Sometimes the involvement of a second organ really is that wake-up call, and I think we've seen that clinically as well.
Great. And for the team from UC Davis, Dr. Wang was asking, who are the patients that you would biopsy if you're, primarily going to be using non-invasive assessment?
So I think similar to our CPMC colleagues, I would probably argue the same, that we'd have to use our clinical judgment. These patients with risk factors for metabolic syndrome, I probably would argue against liver biopsy for these patients. However, there are a subset of patients that might be a little bit equivocal, such as our lean NASH group, where they might not have the obvious risk factors. And so those patients, I'd probably push for a liver biopsy in this setting whenever it's not entirely clear if that diagnosis is actually truly NASH or NAFLD or something else in its entirety.
Great. Dr. Sundaram, any questions from your end?
Yes, I have two questions. I'll start with the UC Davis team, and then if we have time, I'll ask my separate question to the CPMC team. So to the UC Davis team, I think you presented your case very well, but just to kind of stir the pot a little bit, is that regardless of what the studies show, the reliability of transient elastography is just simply not as reliable as liver biopsy, at least in my opinion. And there's a couple of components to that. So one is body habitus, and the other, which I think is a bigger problem in my practice, is kind of the intra-operator variability, where we can get 3 different measurements depending on whether my nurse practitioner or my fellow or I am doing the transient elastography measurements. And so I understand the point you've also made that biopsy is more costly than MR elastography, but from the standpoint of insurance doesn't view it that way. Insurance, I've never had a problem getting a biopsy paid for, but that's not the case with an MR elastography. So given the potential lack of reliability of transient elastography, isn't there a case to be made that a liver biopsy would be a good place to get a baseline fibrosis assessment, which you can then compare to transient elastography and follow serially, particularly in the patients where you can't get an MR elastography?
I think you make some very good points, Dr. Sundaram. So just to actually mention something that I had in my talk, liver biopsy is also subject to inter-observer variability between different pathologists. So that and, that carries the same flaw as you mentioned with transient elastography. So, in isolation, these tests may not be as high of a sensitivity or specificity as liver biopsy, which is considered a gold standard, a somewhat poor gold standard in my opinion. But in what I presented in my presentation was the combination of different non-invasive tests, using the FIB-4 index first and then proceeding to transient elastography. So I understand that getting an MR elastography approved by insurance may be a limitation in terms of access to care. So that is a good point. But however, what the previous question about COVID sort of opened up for me is that we do have to find ways that are more convenient for patients in terms of the time they have to spend inside of a healthcare setting, and as more data comes out using either combinations of non-invasive tests, or more data comes out more thorough data in terms of the non-invasive testing, I think we will eventually have protocols that and approval from the insurance companies that elastography will become standard of care.
Excellent question, Dr. Sundaram. And I think you said you had a second question?
Yeah, is there time?
Yes, please. I think we have time for one more question.
Okay. Then to the CPMC team, again, same sentiments. I think you did a very good job, again, just to kind of stir the pot. So one of the arguments you make is that the advantage of a liver biopsy is to differentiate between NAFLD or simple steatosis and NASH. And I agree that the biopsy is the most definitive way to make that distinction. The argument, though, that you make is that it's beneficial in counseling the patient with regards to prognosis. And I also agree that when you're talking about hepatic-related mortality, morbidity, that it has been more clearly linked to NASH versus simple steatosis. But what has been clearly linked to the development of simple steatosis, particularly in patients who have metabolic syndrome, which is the majority of the fatty liver patients, there has been a clear linkage between steatosis and cardiovascular outcomes. So the question for you is that given that there's no treatments for NASH or NAFLD, and given that there is clearly a prognostic, poor prognosis with regards to cardiovascular outcomes in relation to steatosis. Where does the biopsy help you in terms of ultimately the way you treat the patient? For instance, if the patient has NASH, you wouldn't necessarily be more aggressive in terms of counseling them towards weight loss. I would imagine it would be similar regardless of whether they had steatosis versus NASH.
So I think this becomes important as, right now you're saying there are no FDA approved meds, but that won't be the case forever. There are many clinical trials that are ongoing that we'll be able to provide to our patients soon enough, as well as you already mentioned, providing that really aggressive, we have this diagnosis, these are the outcomes, we have this data, and this is why it is so essential that you make these changes right now.
Excellent, excellent. Well, those were all excellent questions, and you covered several that I had of my own, so that's great. And really congratulations to both teams on excellent and compelling arguments for both the pro and con on this issue. And it's a topic I think will come up again and again, at least for the foreseeable future. So before we conclude this debate, and as we give time for our judges to deliberate on who they feel is the winner, would love to ask the audience again a quick follow-up poll, which you should see now, which asks, did these presentations change your opinion on whether or not you feel biopsy should be the standard of care in NASH? Yes or no? Looks like a little more skewed in the direction of biopsy should be the standard of care than at the start of the session. So let's see if our judges share the same opinion.
All right, so I think the judges are going to actually break away to deliberate for some time, and we're going to take a little pause between our debates. And while we do that, we would, the American Liver Foundation, once again like to express our gratitude to our national sponsors for their support tonight for tonight's academic debate. Our national gold sponsors are AbbVie and NSI. Our national silver sponsors, Salix. The national bronze sponsors are Alexion, Mallinckrodt, and Pfizer. An expo sponsor, Exact Scientists. And as we mentioned earlier, we would like to remind you that you can please donate to ALF's mission. And the ALF supports a lot of our vital work that we do for patients across the country. It's a great resource for patients in our liver community. You can donate by simply clicking on the link that is in the chat box, and however small or big of a donation will really help reach our fundraising goal of $5,000 tonight, and we're really hoping that we can get there. ALF has, there's lots of programming that happens throughout the country with ALF. As Nizar mentioned earlier, this year is the 45th anniversary of the American Liver Foundation. So the mission of the ALF is to promote education, advocacy, support services, and research for prevention and treatment for the cure of liver diseases. And I highly encourage for all the providers in this room, all the fellows on the webinar, to please let your patients know about the resources that ALF offers. The website is www.liverfoundation.org, and you can mention the helpline as well, which is manned by which is answered by liver professionals, and the number for that, very appropriately, is 800-GO-LIVER. So we had a very lively first debate. I think that it will take a little bit of time for the judges to deliberate and try to decide on who. I think that both teams are winners in that debate. They did a fantastic job, but they'll take some time to think about who ultimately had the more persuasive argument. While they're deliberating, I'll share with you a few other programming that's happening from the ALF. So the ALF is also hosting its 45th anniversary Legacy Gala. That's on October 21st. There will be more details provided soon. It's just a month away, but please save the date for this exciting event. And in the event, several folks will be honored, including Dr. Jim Boyer, Dr. Erwin Arias in the Boston Athletic Association. And joining the event will be Sanjeev Chopra, Deepak Chopra, Bakari, and Ellen Sellers. All right. I think we all could use a little exercise stretch moment. And there is a lot of promotion of exercising happening through ALF. There's a cycling event that happens. So for all you cycling enthusiasts, on November 20th, ALF will be hosting its El Tour de Tucson, and it will include 28-mile option, a 57-mile option, and a 100-mile option. The registration fee is $50 with a minimum fundraising goal of $500 per cyclist. And just remember that, you know, the money that's raised through that, again, helps sponsor and pay for many of our patient advocacy events as well. ALF also takes a leadership role in advocating on behalf of the millions of Americans that are living with liver disease and their families and caregivers. We provide expert witness testimony before Congress and state legislature on important issues that are related to liver disease, organ donation, research, and we've been active in obtaining co-sponsors for the Liver Research Enhancement Act, which was HR 1743, to create a center within the National Institutes of Health that will focus solely on research into liver-related diseases. Please consider joining our advocacy list and to lend your support to our efforts. There are large advocacy groups within ALF, and I joined it last year, and it was a really, really nice event. And in my group were patients' family members, other healthcare providers, other patients themselves that you know, that really feel strongly about advocating for change. And I think it's a really important way, besides the medical research we do, I think it's a very important way of creating the change that we want to see in our healthcare system. And another thing that you can consider doing is becoming a social media advocate. So we've got great supporters and very active followers on social media. Today, our Twitter tag, I think, was @ALF Debates. And we want to tap into the enthusiasm and recognize those that are interested in being virtual volunteers so that you can help raise awareness and spread the word about liver disease and the American Liver Foundation activities, events, and initiatives. So that's what we're excited to tell you about our ALF Social Media Advocate Program. And we'd like our social media advocates to already be active on their own, you know, social media handles and networks, but professional experience is not necessary. You don't need to know how to do large tutorials and threads. You can learn that with time if you really need to, but really, what we really are looking for is passion for the cause and desire to be more closely connected to the organization and to promote the mission of the organization, which is truly what we hope for. And together we can really have an exponential impact in getting the public's attention, and that's both providers, it's patients, it's caregivers, it's you know, folks in Congress that might listen to us. So it's important to have as big of a voice as possible if we're able to. On to our second debate now. So just as a reminder, presenters will be sharing a PowerPoint presentation and they'll have 8 minutes to present. Team members providing the rebuttals will not be using a PowerPoint presentation. They'll have 5 minutes to present their case. Each speaker is closely timed, and if at any point a presenter or rebutter exceeds their time limit, their microphone will unfortunately be muted by our timekeeper, not by the moderator. The Q&A for each topic will occur at the conclusion of the presentations and the debate, just like in the last debate. So our second debate is on the topic of, it is a choice between two patients, or a defense between two patients. So which of the following patients is the more suitable candidate for liver transplantation? Stanford University will be advocating that patient A is the more suitable candidate. This is a 32-year-old otherwise healthy woman who's presenting with severe acute alcoholic hepatitis with a MELD sodium score of 32. And UCSF will be advocating that patient B is the more suitable candidate for transplantation, who's a 69-year-old man with obesity, a BMI of 38, diabetes, hypertension, hyperlipidemia, who's presenting with decompensated NASH cirrhosis and the same MELD sodium score of 32. So before I introduce our debate teams, would again like you to answer a quick poll. So based on the criteria I just read, in your opinion, is patient A, the 32-year-old healthy woman presenting with severe acute alcoholic hepatitis with a MELD score of 32, is patient A the more suitable candidate for liver transplantation? And you can answer the poll yes or no. And we'll give you about 30 seconds to respond here. I think it's been about 30 seconds if you want to close the poll. All right, this will make for a great debate. There are 8 people that answered this one, so thank you to those 8, and it's a 50-50 split. So hopefully this will make for a lively debate. We will begin with the team presenting the argument in support of patient A as a more suitable candidate. So this is the team from Stanford University. Their mentor is Dr. Renu Dhanasekaran, and their fellows presenting from Stanford are Dr. Chiazotam Ekekezekie, or Zoe, and Dr. Brandon Tarlow. The presenting for UCSF Medical Center UCSF Medical Center will be presenting that patient B is the more suitable candidate. Their mentor is Dr. Danielle Brandman, and their fellows presenting on behalf of UCSF are Dr. Jin Ge and Dr. Rebecca Kim. We'll begin with Dr. Zoe from Stanford University as our first speaker. We'll give a minute for Zoe to load her presentation. All right, is the timekeeper ready? You may begin, Dr. Zoe.
Thank you. Alcohol-related liver disease is now the most common cause for both liver transplant and listing diagnosis in the US, especially since the start of the COVID-19 pandemic, during which we've seen accelerated rates of alcohol abuse and dependence. Per the OPTN Code of Federal Regulations, the allocation of organs should be based on sound medical judgment, seek to achieve the best use of donated organs while avoiding waste and futile transplants, promote patient access, and be designed to achieve equitable allocation using standardized criteria. The suitability of patients must be considered in the context of 3 principles identified by the UNOS Ethics Committee: justice, autonomy, and utility. The principle of justice requires that equal respect and concern be given to all patients in need of an organ or tissue. It is preserved via fair pattern of distribution of benefits. Historically, many US liver transplant centers mandated that potential candidates must demonstrate at least 6 months of alcohol abstinence prior to consideration for listing. This has been coined the 6-month rule, yet no national or international mandates exist to enforce it. Even OPTN does not explicitly enforce the use of this criterion. The 6-month rule was adopted in clinical practice with the intention to provide time for potential improvement in hepatic function and avoid premature transplantation, which we will later dispute as less relevant, citing Musto et al. Additionally, use of the 6-month rule was intended to serve as a crude index for the predictability of alcohol relapse. However, as supported by the various citations above, this application is unvalidated and arbitrary. Studies have shown that a defined period of pre-transplant alcohol abstinence does not correlate with post-transplant sobriety or compliance. Herrick, Reynolds et al. In JAMA 2021 demonstrate that adherence to the 6-month rule was not associated with superior patient survival or allograft survival between those with ALD transplanted before versus after demonstrating 6 months of pre-transplant alcohol abstinence. Cotter et al. Demonstrate that graft survival between transplant for NASH cirrhosis and ALD are comparable over 10 years of follow-up. Together, these findings suggest that patients with ALD should not be categorically excluded from transplant listing on the basis of the 6-month rule. Beresford et al. Posit that its use suffuses the allocation process with added subjectivity that promotes injustice. The inherent austerity of this rule is likely owing to the bias that ALD is a self-inflicted behavioral choice. However, other indications for liver transplant, like NASH as in patient B's case, or intentional drug overdose with liver failure, could similarly be judged with such bias, but have notably been spared in our literature and practice. The principle of autonomy requires that the personal choices of patients be respected. The UNOS Ethics Committee holds the view that a person's past behavior, including alcohol consumption, obesity, or food addiction, should not be considered as exclusion criterion for transplant. Per the Americans with Disabilities Act National Network, substance abuse is an impairment and becomes a disability if it substantially limits major life activities. In USA v. MGH, a complainant with cystic fibrosis urged that MGH denied him eligibility for lung transplant, citing his history of opiate use disorder and treatment with Suboxone. Under the August 2020 agreement, MGH had to provide the patient and his mother monetary damages, implement new non-discrimination policies, and provide ADA training to medical staff involved in transplant decisions. This recent settlement under the ADA reflects a progressive strengthening of individuals' protections and autonomy via the recent Coronavirus Aid, Relief, and Economic Security, or CARES Act, in effect since March of 2020. Anticipation of how the legal landscape will undoubtedly influence our transplant candidacy deliberations and discourse is prudent. We know that substance use disorders and ALD are not moral failings. Per OPTN, we must respect autonomy because potentially injurious behaviors are known to be significantly influenced by factors over which patients may have little control. And excluding patients from transplant due to these behaviors can exacerbate disparities in health and access to healthcare, undermining not only autonomy, but also justice. Kariq et al. Demonstrated that structured alcohol relapse prevention can mitigate recurrence. Evaluating patients with this awareness can help us promote justice instead of stigma and discrimination. To those who would suggest that transplanting patients with substance use disorder will make the public leery of becoming organ donors, we cite Stroh et al., whose work suggests that it may not be such a controversial practice to the public as previously thought. In fact, early transplant for ALD could strengthen rather than undermine public faith in the ethical integrity, objectivity, and validity of our selection and allocation processes. Irrespective of what is publicly popular, our practice as affirmed by the OPTN Ethics Committee should be committed to the use of criteria that are objective and measurable, reflect the most current evidence available, and be driven primarily by medical benefit, which leads us to our final discussion on utility. The principle of medical utility requires that organs be allocated to patients who are likely to experience the maximum medical benefit. We argue that patient A is more likely to experience the maximum medical benefit offered by transplant based on her otherwise healthy pre-transplant status, in contrast to patient B, who has arguably extensive comorbidities that confer considerable risks towards negative outcomes. Patient A is the more suitable candidate because she's sick and unlikely to recover without transplant. Some argue that early transplant for ALD will lead to increased wasted livers because purportedly they would have recovered on their own. However, as this graph from Musto et al. Demonstrates, patients with severe ALCAP in their study, if they were going to recover, did so quickly and based on factors like younger age and lower peak MELD. If we presume that our patient with a MELD of 32 peaked here and not higher than this, then as you can see, the proportion of such patients who spontaneously recovered in this study was quite low. After 1 week, only 18% of patients with MELD above 32 spontaneously recovered, and this percentage only continued to fall weeks further out. Survival benefit is seen in patients that underwent early transplant for severe ALCAP compared to those treated medically and also compared to those who spontaneously recovered. In this study, patients with severe ALCAP who were not transplanted had a 37% one-year survival rate compared to 90% one-year survival rate if transplanted early. Concordantly, in a 2019 study, Lee et al. Found that offering early transplant to a patient with medically refractory severe ALCAP provided a fourfold increase in life expectancy compared to offering delayed transplant. The net increase in life expectancy persisted irrespective of estimated risk of sustained alcohol use after transplant. In closing, our patient A is the more suitable candidate for liver transplant. We have argued in earlier slides that she's unlikely to spontaneously recover. Due to her lack of comorbidities, she is more likely to maximally benefit from organ transplant and less likely to have as complicated a post-transplant course. With structured therapy and support, alcohol relapse can be mitigated. Refusing her suitability based on her disease process being alcohol-related can violate principles of justice and autonomy, and that refusing her suitability pending a period of pre-transplant sobriety is not evidence-based or objective. Thank you for your time.
Our next presenter is Dr. Rebecca Kim of UCSF. Rebecca, we'll give you a second to get your presentation uploaded. Okay, timekeeper ready.
Okay, great.
Rebecca, you're perfect. Okay, go ahead.
Thank you. My name is Rebecca Kim, and I'm working with doctors Jin Ge and Danielle Brandman on the UCSF team. Today, we will be debating that our patient is an excellent candidate for liver transplantation and should receive a liver over our opponent's patient. We want to thank everyone for the opportunity to participate today and look forward to this debate. I would like you all to meet Mr. Y. He is a 69-year-old man presenting with decompensated NASH cirrhosis and a MELD sodium of 32. In addition to his liver disease, he is obese, has well-controlled diabetes and hypertension, and hyperlipidemia. He is a father of 4 with 7 grandchildren, is still working part-time, and is independent with all ADLs and IADLs. He has a several-decade history of excellent adherence to his medications and physician's recommendations. He has no prior substance use, including alcohol. Today, I need your help to get Mr. Y a liver transplant. Mr. Y is an exceptional candidate, and more importantly, he is the better candidate. I will convince you of this over the next few minutes by focusing on the following points. NASH cirrhosis is the leading indication for transplantation, and post-transplant outcomes are known to be excellent. Alcohol relapse post-transplant is common in alcohol-associated liver disease and leads to worse outcomes. We have tools available for effective risk reduction to ensure good outcomes for our NASH patients. And most importantly, Mr. Y cannot recover from his NASH cirrhosis and will die without a new liver. First, we must all remember that NASH is the present and future of liver transplantation. Using SRTR data from 2002 to 2019, NASH was the second most common indication for liver transplant in 2019, and the most rapidly increasing indication as seen in the graph. In addition, the BMI of patients on the waitlist is increasing, and obese patients are becoming more common. Severely obese patients with a BMI of greater than or equal to 35, like Mr. Y, make up nearly 1/5 of the liver transplant waitlist. These are critical things to consider. Today, if we say no to Mr. Y, at all in part due to the etiology of his liver disease or for his metabolic risk factors, including his weight, we are saying no to thousands of others and ultimately saying no to the future of liver transplantation. So why should we say yes? Post-transplant outcomes for our NASH patients are excellent. Specifically, 1, 3, and 5-year post-transplant mortality for patients with NASH are the same as mortality for other etiologies, as well as for alcohol-associated liver disease. For this reason, among others, we are asking you to give the green light for NASH cirrhosis and Mr. Y. As I previously mentioned, like many other patients with NASH, our patient is obese. Although our opponents may argue his weight negatively impacts his candidacy, that is incorrect. Numerous studies have shown that obese patients do well post-transplant. In a study of UNOS data that included nearly 40,000 transplant recipients, post-transplant mortality and graft failure were comparable across BMI categories. Moreover, from Bamba et al., the risk of death at 1 year post-transplant did not vary by MELD score for obese patients. Instead, it is the low BMI patients that have increased risk of poor outcomes post-transplant. Those are the patients to worry about. On the other hand, Mr. Y will die without a transplant, as waitlist mortality is worse for morbidly obese patients, as shown in this figure. As a result, patients with high BMIs benefit the most from transplantation, measured as a reduction in mortality by 88% versus 80% for normal or overweight individuals. For our second point, patients with acute alcohol-associated hepatitis are at high risk for bad outcomes. When comparing post-transplant outcomes for NASH and alcohol-associated liver disease specifically, there is a striking difference in graft failure. The prevalence of graft failure at each year post-transplant is notably higher in ALD, and overall is over 2 times more in ALD than in NASH. So why do we see such high graft failure in ALD patients? Alcohol use disorder is a devastating disease, and alcohol addiction is not cured with liver transplantation. Unfortunately, over time, an estimated 18 to 50% of patients return to drinking post-transplant, and 1/5 return to heavy or binge drinking. Individuals who resume heavy drinking post-transplant are more likely to have rejection, graft failure, and worse survival when compared to abstinent patients. It is key to remind everyone here today that this comparison between our two patients and the need to select one over the other represents the fundamental struggle of organ transplantation, balancing the needs of an individual with those of the rest of the population. The increased risk of poor outcomes for the patient with alcohol-associated hepatitis hurts the needs of many. Moving on to our third major point, we have tools available for effective risk reduction to ensure a good outcome overall for Mr. Y. Data from 2019 out of Northwestern show that controlled blood pressure defined as less than 140/90 is associated with lower incidence of cardiovascular events and all-cause mortality among post-transplant patients. Additionally, data from Virginia Commonwealth found that statin use for treatment of dyslipidemia after transplantation was associated with 25% increased survival at 5 years post-transplant. It is also critical to treat diabetes post-transplant to reduce the risk of death, myocardial infarction, and stroke. Fortunately, Mr. Y has several years of experience monitoring and managing his blood pressure, cholesterol, and glucose levels. Past behavior can predict future events. We have a long history of adherence for this patient, but not for our opponent's patient. In addition to control of blood pressure and other metabolic risk factors, sleeve gastrectomy at the time of transplant can also be done for our patient, which will lead to sustained post-transplant weight loss. Sleeve gastrectomy also reduces metabolic complications post-transplant. When comparing two post-transplant cohorts, one with sleeve gastrectomy and the other without, post-transplant hypertension, components of metabolic syndrome, as well as hepatic steatosis were significantly reduced in those with a sleeve gastrectomy. I want to conclude with the most critical point. Mr. Y will die without a transplant, and that simply may not be true for Stanford's patient. Even if we were able to guarantee that the patient with alcohol use disorder and acute alcohol-associated hepatitis will do well and not return to drinking, her transplant may, quite frankly, be a waste of a liver. In the STOP-AH trial, even among the patients who did not respond to prednisolone, the overall mortality was high, but only 43.5%. Our opponent's patient may very well improve with supportive management, never requiring a transplant, and allowing the organ to go to someone who cannot survive without it. Someone like Mr. Y, with NASH cirrhosis and a MELD sodium of 32, his overall mortality approaches 100%. Our team, of course, wants what is best for our patient, but just as importantly, we propose what we think is most fair and just. Help each of these patients survive, continue to provide excellent supportive care and addiction treatment and rehabilitation to Stanford's patient, and please choose to transplant Mr. Y. Thank you very much.
Our next presenter will be Dr. Brandon Tarlow, presenting for Stanford University's rebuttal of UCSF's presentation in support of patient A.
Thank you, Dr. Goyle, and I want to thank the organizers and the ALF and the UCSF team for their spirited arguments. So I'd like to use this time to directly respond point by point to Dr. Kim's presentation. And specifically, I want to highlight that our team's argument is that patient A is more suitable for transplant than patient B. So when objective criteria are used rather than subjective and personification is used, we'll find that patient A is going to be the better candidate, which will encompass the values of utility and fairness that Dr. Zhou highlighted in her presentation. Early transplant for alcoholic hepatitis actually is a structured, objective process, and it has more than a decade of both prospective and retrospective data behind it. And finally, we'll make the point that patient B's hypertension, hyperlipidemia, obesity, diabetes, and age, not merely obesity, makes this patient a less suitable candidate and a less suitable candidate than the average NASH patient. So let's put the straw man aside. No one is advocating transplanting patient A if she were to respond to medical treatment for alcoholic hepatitis. Early liver transplant for severe hepatitis is reserved for patients who don't respond. For example, if a patient has a Lyle score less than 0.45, they're likely to be able to have somewhere between an 80% survival. However, patients who do not respond to medical treatment have a dismal response and can have mortality survival rates as low as 25%. Second, I want to highlight the fact that that when a patient is evaluated, they're evaluated as an individual according to an objective and just manner. Alcohol use disorder is heterogeneous, and our patient would be evaluated according to specific criteria to determine if this alcoholic hepatitis was their first decompensating event, if they have in fact failed medical management, if they have a strong support system, just as patient B will be evaluated for other comorbidities such as obstructive coronary artery disease and other features. Dr. Kim raised the question of whether we have enough data to transplant patients with alcoholic hepatitis, and our team argues that we do have enough data to say that patient A is a more suitable candidate. We know that outcomes 1 year after liver transplant for or early transplant for alcoholic hepatitis are comparable at 1 year and 3 years by multiple data sets. And there is increasing data coming as more and more transplant centers in the U.S. publish their results. I want to point out one question, and that's: are we not is how much is obesity a problem? Dr. Kim mentioned obesity itself isn't a problem, and she does have a point. There's about half the studies say it is a problem. The other ones may not have done the proper propensity matching or controlling for ascites, but that's not the question. Is whether the risk that patient B has is attributed to the obesity. It's that it's attributed to the obesity, the hypertension, the diabetes, and the age. In fact, if you look at a University of Pittsburgh study, patients who had all four of these characteristics had a 1 year survival of only 50%. I'm going to say that one more time. Patients with all four of these, 65 and elderly, morbidly obese, with diabetes, hypertension, and hyperlipidemia, could have a 1 year survival of less than 50%. So finally, our team assumes that both patients will die without a liver transplant, and both patients are likely acceptable candidates. But as our team has argued, it's patient A, this 32-year-old woman with alcohol-related hepatitis, is the one that's more suitable. Transplanting her better preserves the values of justice, utility, and patient autonomy, and it can be done in an objective way if she is in fact a good candidate. Patient A is more likely to survive 1, 3, 5 years after transplant, and potentially even decades of productive life. It would be a success if patient B survives into his mid to early 70s. And that we think could have a 50 to 60% chance of happening to reach age 75. We have evidence for excellent transplant outcomes of early liver transplant, as we highlighted.
We'll move on to the rebuttal of Stanford's position by Dr. Jin Ge at UCSF.
Okay, so am I ready? I guess I'm ready. Okay. So it is my job now to give a rebuttal of why should we choose to transplant Mr. Y, our grandfather with end-stage NASH cirrhosis, versus our opponent's patient with acute alcoholic hepatitis. And I want to focus on one sentence that our opponent just said now: if she is a good candidate, if she in fact is a good candidate. We argue that Mr. Y is a better candidate. To set the backdrop, first, both patients, even though they have the MELD score of 32, one patient has a significantly higher survival benefit versus the other one, and that is Mr. Y. And that is because there's no treatment for end-stage NASH cirrhosis. Our opponent's patient with alcoholic hepatitis, even though she has MELD score of 32, she could still respond to aggressive medical management. She could still respond to prednisolone. She has possible therapies in the future, such as DUR 928, which is in clinical trials right now. End-stage NASH cirrhosis with severe fibrosis and portal hypertensive complications does not have an alternative therapy aside from liver transplantation. And I think this goes back to what our opponents argue about the essence of utility in transplantation, how we have to balance utility and justice and respect for all. The liberal expansion of transplantation for acute alcoholic hepatitis may have many externalities that have not been seen and may worsen the equity and long-standing disparities that we've seen in liver transplantation. In previous studies of liver transplantation for acute alcoholic hepatitis, such as Accelerate AH, 73% of patients who ultimately went to transplant were non-Hispanic white, 83% were men, 66% were privately insured. Moreover, 80% of the patients who were denied transplant were denied for psychosocial or financial insurance reasons. And so this gets to the root cause of the problem, is that we don't have consistent criteria for selecting AH patients across transplant centers. In the pivotal studies for AH, only 2 to 8% of patients were actually selected for participation. Some studies even failed to recruit patients over a 3-year period. And studies in the United States had to expand their criteria to include patients who failed attempts with rehabilitation, fail other risk factors that would not be acceptable across many, many centers. In NASH, in contrast, we do have objective criteria for screening of CAD, for diabetes control, for cutoffs for BMI, for medication adherence. We have objective criteria, and we have widespread uniform cutoffs and also testing to make these patients be eligible for transplantation. And Mr. Y has demonstrated that he is able to follow medical advice and is able to take off all his medications and get his comorbidities under control. Now, in a survey across 45 transplant centers, Bengaru et al. Found that criteria for listing for AH lacked consistency across centers with regards to requirements for rehabilitation, pharmacotherapy, and also awareness for having previous liver disease. While the Dallas Consensus Conference in 2020 established some overarching principles for listing selection, the authors of this AASLD selection practice guidelines said that the most critical issue is how to best consistently and uniformly select appropriate patients who have excellent post-LT survival and low risk of relapse following LT. And in the post-transplant setting, going to the question of relapse, we're not doing that much better because we don't have accurate tools to predict who will return to harmful drinking. Notably, 22% of the patients in Accelerate AH and across other studies of transplantation and alcoholic hepatitis return to high-risk drinking. So, and the problem is that our models are not great. The SALT score, which was developed here at UCSF, has a sensitivity of 55% and also a positive predictive value of 25%. The alcohol relapse assessment, relapse risk assessment score was only a single center retrospective study that's not validated anywhere else. The Stanford Integrated Psychosocial Assessment for Transplantation was neither built nor validated for post-LT alcohol relapse. And then finally, the University of Michigan Alcoholism Prognosis Score was a single center study, and the score was not actually even associated with post-transplant alcohol use. And that highlights another major issue, is that return to alcohol use after post-transplant is associated with graft failure in this patient population, whereas recurrent NASH is not associated with graft failure. So I think the one major point that we have to emphasize is that our opponent's patient has a chance at medical therapy. There are 104 clinical trials currently occurring for potential therapeutics for alcoholic hepatitis. Our patient, Mr. Y, has no other options. He has the survival benefit. Without a transplant, he will 100% chance of dying, whereas our opponent's patient has a greater than 40% chance of survival even without a transplant. We want to transplant both patients. We understand and we agree at this point. But at this time, our grandfather with NASH cirrhosis is clearly the better choice to be transplanted today. Thank you so much.
Thank you, Dr. Gito, sir, for very passionate arguments in support of patient B. We will now begin the Q&A session. So I'd like to welcome back our judges, Dr. Marina Reutemann, Dr. Vinay Sundaram, and Dr. Robert Wong. And I'd like to welcome both of our teams back. We'll give a minute for all of their videos to pop on. And, you know, just as everyone gets back on screen here, it does seem like such a central crux of both teams' positions really relies on the ethics of transplantation and the principles of justice, autonomy, and utility. So I hope that, you know, with the judges and with some of our Q&A session, we can get to the heart of some of these ethical questions between these two patients. So I will ask the judges, anyone want to start off with a question?
I'll start.
Thanks, Dr. Reutemann.
First of all, I want to thank you both for both teams for excellent presentations. I have patient A and patient B on my service as of today. So I am very glad to hear your input and give me further food for thought. Having said that, my question is to the Stanford team. you mentioned that the post-transplant success of a patient with underlying alcohol-related hepatitis really relies on access to treatment and access to substance abuse care after the transplant. My question is, do you feel that we are ready to provide our patients with access to this much needed care? Because I can tell you that in the Central Valley, we're not.
Thanks, Dr. Reutemann. So that's a question directed to the Stanford team. So either Dr. Tarlow or Dr. Zhou, do you feel like we have the adequate alcohol use disorder treatment resources for our potential transplant recipients?
First, I want to start by saying thank you so much for that very thoughtful question. I think that there are many different ways of answering this question. I think one of the things that gives me some reassurance is that in this effort, we are not all alone. As we, looked through various implementation science efforts to try to optimize and meet this sort of need, what each of these papers that we looked at really capitalized on is the fact that in order for patients like this to have adequate support, it is not solely the healthcare center is not the sole nexus through which that support is achieved. And I think that part of the assessment, it's really crucial and important to not only enlist the patient, but also the patient's loved ones and their community at large. So I think that the answer is across the board. I think that if you look at how our understanding of the opioid crisis has really evolved, I think that there's increased enthusiasm and passion to really try to meet the unique needs that patients with substance use disorders face. And so I am optimistic that with this enthusiasm, we'll be able to persist in our efforts to discover how to fill that gap. I think it's possible, and I don't think that we should give up simply because at the present moment, things aren't perfect.
Great. Thank you, Dr. Zhou, for that answer.
I can go next. I have a question. This is more of an ethical type of question. And as both of you, I think, emphasize quite well when thinking about a patient that's potential, transplant candidate, we consider the individual, but also we take a step back and think about the public health aspect of it, healthcare resource utilization. So my question for both of you is, how do you approach the ethics of thinking about how much or to what degree this individual can contribute back to society if he or she were to get a transplant? On one hand, you have a relatively young, relatively healthy individual, but also has a history of substance abuse and may have high risk of recidivism, and so potential may not contribute as much as someone else. And on the other hand, the other team has a relatively elderly individual, has multiple comorbidities that even if he were to get a transplant, may still stress and utilize a lot of healthcare resources and may not be able to contribute back as much as we want. So I'm curious to hear both of your thoughts on that aspect of thinking about liver transplant.
Wow, that's a completely different dimension of no, that's great. This is a completely different dimension of the debate that wasn't really brought up by either team before. So I think it's a wonderful question. Anyone want to take the first stab at responding, either UCSF or Stanford?
I can take a stab at this. Thank you so much, Dr. Wang, for this really thoughtful, insightful, and also thought-provoking question. To go to your point, I think we have to be very careful in sort of like how do we assess each candidate's utility or sort of like their ability to contribute to society. I think the one mistake that we should not engage in is actually ageism and say that just because Mr. Y is 69 years old, he cannot contribute to be a productive member of society versus our opponent's patient who is much younger. And the way that we set it up was that Mr. Y is a grandfather of 4 children, so he does take into caregiving situations for those children. He's very well controlled with his diabetes and all of his comorbidities, and we expect him to actually be able to survive at least 10 years with his new transplant, and he's able to contribute to society in that matter. And I think it's one of those things that we want to be careful in that we're not arguing that we should not transplant the patient with alcohol use disorder or acute alcoholic hepatitis, but our argument is that Mr. Y is the better candidate because he does not have any other alternatives. Whereas the patient with acute alcoholic hepatitis, they may very much recover from their acute episode and go on to live productive lives if their liver recompensates. And we've seen that all the time in our clinical experience, that somebody has an episode of ALCAP, gets over it, shows up in clinic, and improves with aggressive medical management.
Thank you, Dr. G. Stanford team, would you like to respond to Dr. Wong's question?
Sure. Thanks, Dr. Wong, for the question. It's I think a difficult question in terms of how to apply some of the principles that we use in transplant in terms of justice for each of the patients, respecting their autonomy, and then the utility is. We don't want to make the argument that this is just a utilitarian principle, but I think we do have to determine whether if patient A is going to be a patient that has a treatable alcohol use disorder, we would want to find somebody who is evaluated for their ability to engage with society. I think the other team has chosen to apply a lot of personification, and it's very nice attributes to Mr. Y. I think the fact is in the same way we would want to exclude a patient who's fragile, who's elderly and fragile, is going to get CKD at a rate of about 30%, and may be in and out of the hospital and unable to care for those grandchildren.
I'd like to make one additional comment, if that's okay.
Yeah, go ahead, Dr.
So to answer Dr. Wong's question also, I think that kind of to piggyback off what Dr. G said, we have to be careful about ageism, but we also have to stress the importance of our patient's biological age compared to his chronological age. So certainly not all 69-year-olds are the same. We do all know the importance of frailty, and we have applied that assessment to him. It is something that we have objective data for, and we can say that he can perform well post-transplant. I think the challenge is that our opponents argue that we can treat alcohol use disorder, and while we can, we actually don't know how to treat it post-transplant, and that's really the challenge. We know how to treat diabetes post-transplant, we know how to treat high blood pressure, and these are things that Mr. Y has actually already done. While we really want to give patient A the benefit of the doubt, we actually don't know how best to help her post-transplant. So we're kind of making the assumption that she will do well, and I hope that she can, but we don't know how to better support her if unfortunately she doesn't.
In all fairness to the Stanford team, I'm going to see if Dr. Zhou wants to also comment.
Thank you so much. I appreciate that. So just want to clarify 2 quick things here. So first of all, we actually don't know objectively that Mr. Y's diabetes is effectively controlled. I understand some of the creative license taken towards creating a patient narrative with some embellishment, but we don't have any objective markers of such as an A1C, for instance, or a glucose log, for example, to really corroborate that his blood sugar is effectively controlled. And the main thing that I want to make sure that we effectively contextualize is just not only are we discussing the risk with respect to how patient Y will do or patient B will do after transplant, but my colleague has brought up some really important things to consider about whether or not patient B will actually survive the transplant itself. BMI of 38, known to make the surgery far more complicated. known to make the procedure, the operation, far longer. These patients are known to have far more biliary complications post-transplant, far more infections post-transplant. What I do want to contextualize also is his ASCVD risk alone, based off of the features that they have offered, is 40%. 40%. That's incredibly high. So we really need to consider whether or not this patient will survive the surgery itself. And then in addition, also consider how likely this patient is to do over time, given that metabolic syndrome and these factors that go into metabolic syndrome will likely persist as issues for him postoperatively.
Okay, thank you for the discussion to Dr. Wong's question. That was a very lively discussion. Thank you. We are running late on time, and but I do want to, Dr. Sundaram, do you have a quick maybe question for the teams?
Yeah, I'll have one quick question then for the UCSF team. The question is that the premise of the argument, at least in part, is the possibility of the patient improving. Number one, that the patient has a pathway with regards to steroids, or even if they're a steroid non-responder, the patient may still improve. But the data with regard to the Lille score does show that the prognosis is rather poor, 25% survival. So my question is, at what point would you pull the trigger and say to the patient, okay, you do need a transplant and you're probably not going to survive without one?
I think.
Go ahead, Jen.
Thank you, Dr. Sundaram, for the wonderful question. But I think the nuance of the argument that we want to argue is that who is a better transplant candidate at this point in time? And I think based on what you said, the possibility of response to a medical therapy, even though that's not guaranteed, but there is possibility of response. And versus the fact that our patient with NASH cirrhosis that's decompensated and has a MELD of 32 is most likely going to die, it has a higher risk of dying in the short term. We believe that patient Y is going to be the better transplant candidate at this time. We want to transplant both patients. I think there's no doubt about that. I think that's agreement between us and both the Stanford team. But because of the organ allocation system that our system imposes on us and the fundamental mismatch between donors and a number of candidates, we have to choose we have to choose between two candidates for priority right now. And the argument that Dr. Kim and I are making is basically that Mr. Y is the better candidate at this point in time. And I want to also comment on some of the issues that our Stanford colleagues had offered regarding Mr. Y's candidacy. At UCSF, we do have these criteria for evaluation of CAD, control of diabetes, and also complication of metabolic syndrome before they are posed as a candidate for liver transplantation. And I'm sure the same occurs at Stanford. And so if somebody is a candidate, which we're saying Mr. Y is, he had to have a cardiac evaluation that shows that he has no CAD, or at least non-obstructive CAD that would not be prohibited for surgery. He has to have good control of his diabetes. His BMI must be under 40 for him to be considered a good candidate. And so while I understand that our opponents have a lot of reservations about that, this is standard operating procedure for us at our center, and I'm sure across multiple centers around the country. Whereas the fundamental issue with candidate A, patient A, is that we don't have good objective criteria that's uniform, that's across transplant centers for evaluation of alcoholic hepatitis. Thank you.
Thanks, Dr. G. And Stanford, would you like to respond to Dr. G's answer?
Yeah, thanks, Dr. G. Yeah, I'd like to respond. I take all his points that there's a process for evaluating, but I think we're having a little bit of a different debate. We've had a chance to review all the literature of all these programs in the United States and in France who have data. There's nobody in the world, I think, who wants to transplant a patient who's going to recover from alcoholic hepatitis. And so I think that's a straw man argument. There's a process at this point. I agree that there's no process that's across centers that's completely standardized, but our experience at Stanford, which has been a little more proactive at transplantation with alcoholic hepatitis, we absolutely have a rigorous standardized approach that may be a little bit different than what's done in France, but it has internal consistency, it has steps, and it has a comprehensive support from a skilled social work and a psychiatry team that has taken years to build.
Great. Thank you, both teams, the judges, for such a lively discussion. I think, Dr. Reutman's comment at the very beginning that she's on service right now and both of these patients are on service just comes, I feel that these are patients that we take care of all the time. And I think these are very real clinical decisions we have to think about. So one final poll, we'll let our judges deliberate now and discuss the winners for all the debates, for both the debates. But one final poll while they're deliberating, based on the presentations, have you changed your mind on which patient is more suitable for transplantation? So I believe, Nizar, correct me if I'm wrong, I think last time it was 50-50. We'll give everyone about 30 seconds to respond. Most people have not changed their mind, maybe, but 3 people did change their minds. That's interesting. I wonder which way they went. All right, so that's a sign of a great debate. Everyone did a wonderful job, and I think very enlightening discussion and amazing amount of data shared. I think we all learned from everyone's discussions. So as the judges are deliberating, we'd again like to remind the viewers that this is the last opportunity that you have to donate. We are truly grateful to our audience members who took a moment to donate already. And if everyone would just take a few seconds to look in the Q&A box, you will find a link to make your donation this evening. So go ahead and click that Q&A box and make that donation. I'm going to give everyone a minute to do that. And remember, our team's work, you see just 13, maybe 20 minutes of presentation material, but the amount of effort, that the fellows put in with their mentors to prepare, and the amount of research that they did to really prepare for this debate is incredible. And I think it's obviously a learning experience for the fellows, but they really do, I think, teach all of us, the audience members, the moderators, all the participants, they really do teach us a lot in the process of preparing. So please acknowledge their hard work tonight as well by making a donation. And while you're making your donation, we begin making closing remarks. All of our mentors and debaters will join us for the final comments of the evening. While we will wait for the judges to come back from deliberating before we obviously announce the winning teams. I think the debates were fantastic, Nizar, don't you?
Absolutely, and the gloves were coming off, the cerebral gloves were coming off, and especially in that second debate. So I'm curious to see what our judges think. All the teams really did a phenomenal job.
I think the involving alcohol and ethics always brings a different passion out from the debaters. But I really did enjoy the discussion at the end. I think the questions were fantastic.
Yes, and so like Dr. Goel, I'd like to congratulate all of the teams on an outstanding job and thank their mentors for their expert guidance and the judges for the thoughtful questions, and the American Liver Foundation tech team. Thank you for helping us arrange this event and for joining us this evening. I'd like to also mention our national sponsors one more time, the national gold sponsors, AbbVie and Eisai, and the national silver sponsor, Salix, and the bronze sponsors, Alexion, Mallinckrodt, and Pfizer, and the Expo sponsor, Exact Sciences. As a reminder, the American Liver Foundation actually hosts debates, academic debates across the United States, and you're welcome to attend these now that everything is virtual. It's really nice. So you can register for these virtual programs, and we've placed the dates there. And as you can tell, it's very entertaining and nice way to get the latest data and evidence-guided evidence on really pertinent clinical topics. So please remember to visit the ALF website and recommend it to your friends, family, colleagues, and patients. And as a reminder, there are many resources for liver patients that you can direct them to, including a helpline and educational programs for patients and healthcare professionals. And we encourage you to visit these links and explore them, and then encourage your patients to visit them too. ALF helps connect, again, the liver community through various events like the Cuisine for a Cause, Liver Life Walks, and 45th Anniversary Legacy Gala coming up in October. And so more details will be sent out to you about that. Please use the social media to advertise these events, and like us on Facebook and follow us on Twitter and Instagram.
So it looks like everyone's ready. So if all the teams, mentors, judges can turn on your cameras, that'd be great.
All of our teams have performed exceptionally well. Thank you for sharing your countless hours of research, elevating our understanding of these two very controversial topics and their benefits and drawbacks, and devoting your time to improving patient outcomes. Truly, everyone here is a winner tonight, healthcare community, patients, caregivers, and the general public, because of the work that you've done. So thank you so much.
Definitely. So I'll go ahead and announce the winner of debate number 1. Remember, this was biopsy should be the standard of care to assess non-alcoholic steatohepatitis. CPMC was on the pro side, and UC Davis was on the con side. The winner is UC Davis for this debate. So hats off to you guys and congratulations.
Bravo. Okay, and so for the second debate, which was which patient is more suitable for liver transplantation, Stanford argued that the 32-year-old woman with severe acute alcoholic hepatitis is the more appropriate candidate, and UCSF argued that the 69-year-old with obesity and metabolic syndrome with decompensated NASH cirrhosis, MELD sodium of 32 is the more appropriate candidate, and the judges have decided UCSF are the winners of this debate. Congratulations to you all. So thank you all for joining. I hope you found this interesting and exciting. I certainly did, and definitely will take all the information you provided to heart as we see these patients every day. So thank you, and see you next year. Everyone stay safe and stay healthy.
Thank you, everyone.